A very good evening all and welcome to UPDA ki Pathshala, which is presented by Uttar Pradesh Diabetes Association. The topic for today is COVID and hyperglycemia, and we are here, Clarnet, the digital partner, to provide the digital platform for the session. So here I have a small video of Clarnet which I will be sharing, and after that we'll start with the session. Thank you all for watching the video. Now I would like to introduce our the moderators for today. Dr. Narsingh Verma sir. Sir is a professor, Department of Physiology and head of the Department of Family Medicine, KGMU Lucknow. Sir is the Secretary General of Indian Society of Hypertension and Indian Society of Chronomedicine. Sir is the President of Asia Pacific Society of Hypertension, President of Association of Physiologists of India, President of UP Diabetes Association, Secretary of UP Chapter of RSSDI, President of International Association of Medical Nutrition. He has a lot many to say about, but skipping all of that and going to the next moderator for today, Dr. Sanjay Arora sir. Sir is a member of CSI, member of UPDA, RSSDI, Fellowship in Diabetes from CMC Fellow Diabetes India, Fellow of UPDA. Sir is a General Secretary, API Lucknow Chapter and Secretary of UPDA. Third moderator for today is Dr. Manoj Kumar Srivastav sir. Sir is a member of the governing body of Indian Society of Hypertension, member Endocrine Society USA, Vice President UP Diabetes Association, Vice Chairman of Organizing Committee of BPCON 2020. These were very short introduction of all our moderators. They have a lot to add to this list, but moving on to the session, and we'll hand over the session to Dr. Narsingh Verma sir. Over to you, sir.
डॉक्टर संजय अरोड़ा सर. संजय अपने को अनम्यूट कर लीजिए. संजय.
जी. Good evening. On behalf of UPDA, I welcome you all to this program of Diabetes UPDA ki Pathshala. After a successful conference of UPDCon in December, we are again gathering on this online platform. We had a really successful UPDCon conducted by Secretary Dr. Manoj Srivastav at that Secretary of the Organizing Committee. And we had more than 950 record participants online attending the program. After that, we had one governing body governed by our president, Dr. Narsingh Verma. And now with this development of COVID, a lot of chaos had happened, and it was the idea of a president that we should start some activities and have something going on in our UPDA platform. तो उसके लिए फिर डॉक्टर नरसिंह वर्मा ने कहा कि हमारा एक हिंदी में प्रोग्राम होना चाहिए यूपीडीए का, यूपीडीए की पाठशाला. एंड इसके लिए फिर कुछ टॉपिक्स उन्होंने डिसाइड करे एंड कुछ स्पीकर्स डिसाइड कर रहे. एंड क्रोनोलॉजिकल ऑर्डर रखा कि हमारे सबसे सीनियर मोस्ट एक्स प्रेसिडेंट डॉक्टर प्रोफेसर गर्ग को हम लोग सबसे पहले इनवाइट करेंगे। तो उसको प्रोसीड करते हुए हम लोगों ने ये प्रोग्राम रखा है एंड इट्स अ प्रिविलेज टू हैव एवरीवन आउट हियर। मे आई आस्क आवर प्रेसिडेंट to take over the sessions for further proceedings.
थैंक यू संजय, थैंक यू संजय। आपने अपना समय निकाला क्योंकि सेक्रेटरी यूपीडीए से ही शुरुआत होनी थी, तो आपने अपना समय निकाला आज के कार्यक्रम के लिए। बहुत ही अच्छा लग रहा है और मैं सबसे ज़्यादा धन्यवाद देना चाहता हूं अपने गर्ग सर का, क्योंकि गर्ग सर ने शुरुआत एक तरह से की थी उत्तर प्रदेश डायबिटीज एसोसिएशन की, प्रोफेसर AR सरकार साहब के साथ मिल करके। और मैं उनसे बात कर रहा था कि जो पौधा उन्होंने लगाया था वो आज बड़ा वृक्ष बन रहा है। और मैं इसके पहले आगे बढ़ूं, मैं प्रोफेसर गर्ग साहब का एक संक्षिप्त परिचय देना चाहता हूं। हालांकि डॉक्टर गर्ग बहुत वेल नोन है और सबसे बड़ी बात ये ब्रिगेडियर होने के बाद भी हम लोग कर्नल गर्ग ही कह देते हैं और सर बुरा नहीं मानते हैं। और सर इस समय मेडिकल सुपरिटेंडेंट है और प्रोफेसर HOD हैं मेडिसिन और एंडोक्रिनोलॉजी के एम्स जोधपुर में, और पास्ट प्रेसिडेंट UPDA रहे हैं सर, मेंबर एक्जीक्यूटिव कमेटी ISBMR, साइंटिफिक चेयर नॉर्थ ईस्टर्न डायबिटीज सोसाइटी के रहे हैं। सर को बहुत सारे अवार्ड मिले हैं, अगर उनकी पूरी लिस्ट पढ़ूंगा तो मुझे लगता है कि पूरा कार्यक्रम उसी में समाप्त हो जाएगा। लेकिन कुछ उसमें से लेफ्टिनेंट जनरल रंगा राव ट्रॉफी फॉर बेस्ट ऑफिसर, Lieutenant General B.D. Verma Silver Medal for first position in MOJCC 98 at FMC Pune, Best Paper Award at Novo Nordisk Diabetic Update 97, Dr. B.C. Mehta and J.C. Patel Award for JAPI 2000, National Best Referee Award at 2011, Best Research Paper Award UPDA 2012, Best Research Poster Presentation in ASICAN 2013, Dr. Subhas Mukherjee Memorial Oration, ASICAN 2014, Chief of Army Staff Commandant Card 2015, Most Cited Paper Award in Journal of Cardiology 2016, Professor Sarkar USB Oration at Uttar Pradesh Diabetes Association 2017, Research Paper Sir के 260 से ज्यादा हैं, more than 260 in international and national journals, and citations more than 3,200. So I salute sir for this commendable work, because at the age I think 62 मेरी एज हो चुकी है। मैं अभी तक लाइफ में मेरे केवल 222 पर्चे हैं और केवल 1200 साइटेशन है, तो इसमें सोच सकता हूँ सर के 3200 साइटेशन है। बहुत बड़ा काम है सर का। स्पेशल इंटरेस्ट सर का पिट्यूटरी, थायराइड, विटामिन D, BMD, न्यूट्रिशन, डायबिटीज एंड व्हाट नॉट, एवरी फील्ड वी हैव सीन प्रोफेसर गर्ग। तो इस छोटे से इंट्रोडक्शन के साथ, मैं छोटा इसलिए कह रहा हूं कि सर का इंट्रोडक्शन बहुत बड़ा है लेकिन समय का अभाव है। मैं प्रोफेसर गर्ग सर को इनवाइट करता हूं कि अपना प्रेजेंटेशन करें और उसके बाद हम लोग चर्चा करेंगे। तब तक आप लोग अपने प्रश्न चैट बॉक्स में डाल सकते हैं, उनके उत्तर, सभी के प्रश्नों के उत्तर अवश्य दिए जाएंगे। प्रोफेसर गर्ग सर।
नमस्कार, UPDA की पाठशाला मैं आप सबका स्वागत करता हूं। बहुत अच्छा लग रहा है आप लोगों के साथ जुड़ने का। नरसिंह जी ने जब मुझे बोला कि ऐसा काम करना है तो मैंने कहा मैं कभी मना कर ही नहीं सकता। UPDA के लिए मेरा जी जान ऑलवेज हाजिर है और वो हाजिर रहेगा। 2020 दिसंबर 2019 में जब वुहान से ये कोरोना वायरस निकला और फिर धीरे धीरे पूरे संसार में फैलने लगा, 30 जनवरी 2020 को पहली बार इंडिया में फर्स्ट केस मिला। ये एक अननोन एनिमी था, कोई बाउंड्री नहीं थी, कहां से आ रहा है, हर तरफ था और इसके बारे में हमें बिल्कुल भी ज्ञान नहीं था कि ये क्या है, कैसे है, क्या करेगा। ऐसे में चूंकि अननोन एनिमी था तो हमने एम्स जोधपुर में एक वॉर रूम बनाया, जिसमें आप देख रहे हैं हमारे डायरेक्टर सर बैठे हुए हैं और सब HODs हैं, एनेस्थीसिया, पल्मोनोलॉजिस्ट, मैं, बायोकेमिस्ट, पीडियाट्रिशियन, everybody was there and we started making the plans that how to tackle it. So इस अननोन एनिमी से लड़ने के लिए किसी को मालूम नहीं था कि कौन सा वेपन काम करेगा और कौन सा वेपन काम नहीं करेगा। If you look at chronology, तो हम लोगों ने मार्च 2020 में तैयारी कर दी, जिसमें हमने पहले सब लोगों को, रेजिडेंट डॉक्टर सबको बताया कि क्या चीज है, क्या हो सकता है, वार्ड का मैनेजमेंट किया, सबकी ट्रेनिंग चालू की, हमने अपनी एसओपीज बनाई, और हमारे यहाँ पहला केस 25 मार्च को 2020 में भर्ती हुआ। तब से लेकर आज तक हमारे एम्स के अंदर 1,42,000 हम टेस्ट कर चुके हैं, जिसमें से करीब 22,218 पॉजिटिव, अराउंड 15.6% पॉजिटिव है। दिस इज टुडेज मॉर्निंग रिपोर्ट। हमने करीब 5,854 केस एडमिट किए, जिसमें करीब 1,007 की डेथ हुई, दैट इज 7.2%. दिस इज बिकॉज we were admitting only moderate and severe cases. Mild cases we were handling at home. So this is the representation not of the complete COVID cases, but only moderate to severe cases. And then we started doing our search also in the COVID area. It is हमारे पहले से ही हमें सबको मालूम है कि जब अगर हम कभी भी इन हॉस्पिटल मॉर्टिलिटी लेते हैं और एडमिशन के टाइम की जो ब्लड ग्लूकोज होता है, इट अफेक्ट्स द मॉर्टिलिटी. एंड इफ यू लुक एट द वेरी वेरी लार्ज पॉपुलेशन ऑफ द ग्रुप, जब भी ब्लड ग्लूकोज 70 से नीचे जाता है तो मॉर्टिलिटी इन हॉस्पिटल मॉर्टिलिटी परसेंटेज बढ़ते जाते हैं, और जब भी 100 ऊपर से जाता है तब भी ये मॉर्टिलिटी सिग्निफिकेंटली बढ़ती जाती है. तो ये हमें पहले से मालूम था. बट ये कोविड में अगर ऐसा होता है या नहीं होता है, तो इसके लिए सबसे पहले पीसा एट्रिस स्टडी आई, जिसमें उन्होंने 271 केसेस एनालाइज किए. इफ यू लुक 21% वर डायबिटिक, दैट मींस डायबिटिक्स वर मोर देन द कॉमन प्रेजेंटेशन इन द पॉपुलेशन. एंड इफ यू लुक एट द ग्राफ, whether it is a normoglycemia, hyperglycemia, or diabetes mellitus, all were having the hazard ratio was much more in the patient with hyperglycemia, means those who were not a known diabetics or in the diabetics. So the new onset hyperglycemia had the 2 times more mortality and 30 times more mortality than the known diabetics. And if we divide the admission blood glucose as quantiles, you can look the lowest, highest quantiles were having the higher mortality. This was not only from the Italy, this was also represented in the US, where if you look at patients with the diabetes who are diabetics, they get more admission to the ICU. So first there was more cases of the COVID among the diabetes. Those patients who were having the diabetes, they were more likely to get the ICU admission. में ICU में admission ज़्यादा हो रहे थे, उनको मैकेनिकल वेंटिलेशन मतलब वेंटिलेशन पे ज़्यादा जा रहे थे, और उनमें डेथ भी बहुत ज़्यादा हो रही थी. और ये ट्रेंड अमेरिका का था. और इफ यू लुक एट द स्पेनिश स्टडी कोविड रजिस्ट्री, जिसमें करीब 11,000 उन्होंने पेशेंट्स लिए. एंड इफ यू लुक एट ऑल द पेशेंट, whether they are diabetic or non-diabetic, if they are admitted with the high blood glucose, their mortality was almost double than those who had the normoglycemia. So it is not only the new onset diabetes or diabetes, it is the admission hyperglycemia which were more culprit. So if you look at the blood glucose of more than 180, they had the double the mortality than those who had the less than 140. Then they did the meta-analysis and same thing came out. If you look at the upper one, it is for the severe or critical cases, that all the diabetic patients, non-diabetic patient at the admission hyperglycemia. Again, these were the non-diabetic, and at admission they had the hyperglycemia. They had almost 2 times more chances of getting critical, and they were more likely to get ventilated. And they had around 2.5 times more mortality, those who were non-diabetic even admitted with the hyperglycemia. And then we also did the study when it started, as I told you, from 15 May to 30 June, 45 days, we had the 386 patients, and among them, if you look at 17.4% were diabetic and 10.3% were the new onset hyperglycemia. So if you look at almost 28%, 1/4 of the patients had the hyperglycemia in COVID times. And if you look at this graph, if you look at the plasma glucose and C-reactive protein, they were positively correlated. That means diabetic patients have the more underlying inflammatory markers or inflammation. When we look at the random plasma glucose at admission and compared from 100, 100 to 120, 200 to 300, more than 300, the hazard ratio for this is odds ratio, sorry, it is a mortality was 0.6% and it increased to 28% when blood admission blood glucose was more than 300. So if blood glucose is more than 300, you can think that 1/4 of the patients are going to die. And the unadjusted hazard ratio was around 4 times in these patients. Continue with that study. If we look at our data, if you look at the WHO severity grading, it is asymptomatic, mild, moderate, severe, and critical. The blood glucose level was continuously rising. That much patient admitted with the severe, जो भी severe patient भर्ती हो रहे थे, उनका admission blood glucose बहुत ज्यादा था. मगर not disheartening, mild cases भी देखें तो इनमें भी ज्यादा blood glucose था, वो भी ठीक हो रहे थे. But if you look at the critical patients, their blood glucose was much higher. And if you look at the Cox proportional hazard ratio, between those admitted with the less than 180 and more than 180, जिनका भी blood glucose more than 180 था, if you look, they have the hazard ratio which was 4 times higher than compared to those who had the blood glucose less than 180. So at present, we look at the criteria of the blood glucose acceptable is less than 180. So any patient, we require that they should have the better control during COVID times, even if they don't have the COVID. So when they get the COVID, their blood glucose should be less than 180, so the mortality will be less. That was the message we wanted to give to every patient of the diabetic, that those who are diabetic, they do not get lax and they should control their blood glucose throughout, so that even if they get the COVID, their mortality rate will be lower if their blood glucose is controlled. Why this is all happening? If you look at the SARS-CoV coronavirus, it has the direct predilection for the beta cell because they exhibit the ACE receptors, और ACE receptors से they get attached और वो pancreatic beta cell को damage करते हैं. Along with that, they have the cytokine storm, as I've told you, that they have the lot of cytokine storm, IL-6, TNF-alpha, IL-1, many more known or unknown. And this both combined, they causes the admission hyperglycemia. Those who are already having diabetes, they cause the worsening of the metabolic control, and they probably cause the new onset diabetes also. Along with these patients, they have the obesity, they have the inflammation, they have coagulation, they have the older age, hypertension, underlying cardiovascular disease, as well as the renal disease. And these all combined, they lead to the poor outcome. If you look at the beautiful diagram given by the Fieldman, one side you look at the COVID, which is the acute condition, and one side you look at the diabetes, that is the chronic condition. So you have the already chronic dysfunction in the body in the form of the low-grade inflammations, you have the insulin resistance, you have the slowly progressing cardiovascular disease, kidney disease, neuropathy, brain changes, glucose variability, hypercoagulabilities, endothelial dysfunction, and fibrosis. And on this, we have the super added coronavirus. And they have the similar thing, but in the acute phase. They already have the soil on that they flourish. So if you look at the COVID, they have the acute cytokine storm with inflammatory response. They have the acute damage to the kidney, heart, lungs, neurology, hyperglycemic changes, hypercoagulability, endothelial dysfunction, and fibrosis. So when they both combine, they cause the much more damage and outcome is poor. So in corona diabetes outcome study, where they took the 51,000 patients, those patients who had the previously microvascular damage, जिनको retinopathy थी, neuropathy थी या nephropathy थी, odds ratio for mortality was 2 times higher. And also those who had the macrovascular complication in the form of the cardiovascular disease or the stroke, they independently associate with the 2.5 times more mortality. So also acute complications were more common in the COVID times because COVID, firstly, it's developed suddenly. It damages the beta cell suddenly. So your insulin deficiency occurs. And because of this insulin deficiency, they develop the hyperglycemia or diabetic ketoacidosis. in the this corona diabetes outcome study, there was the 19 cases of the diabetic ketoacidosis, and we have also seen many cases of the diabetic ketoacidosis coming and presenting as a decay, and when we did the RT-PCR, they were positive. And this all were happening because the virus bind with the ACE2 receptors, and there is a sudden insulin deficiency leading to the HONC or diabetic ketoacidosis. So now what to do? So now I have told you that diabetes, firstly, they get the more COVID infections. Once they get, it is more severe. They are more likely to get ventilated, and they are more likely to have the death. If they are uncontrolled, even non-diabetic patients admitted with the hyperglycemia are at risk of death and the poor outcome. So now how we should manage? इसके लिए सबसे पहला ये डॉक्टर निखिल टंडन एम्स वालों ने पब्लिश किया है. मुझे बहुत अच्छा लगा कि जब भी कोई एडमिट होता है तो सबसे पहले उसका रैंडम कैपिलरी ब्लड ग्लूकोज कर लिया जाए. दूसरा, जब वो दूसरे दिन उसका प्री मील और फास्टिंग कैपिलरी ब्लड ग्लूकोज कर लिया जाए. और तीसरा, अगर पेशेंट का फास्टिंग और HbA1c भेज दिया जाए. ये काम अगर 2 दिन कर लेते हैं और आप देखते हैं कि ब्लड ग्लूकोज लेस देन 180 है, तो आप पेशेंट को मैनेज करते रहिए. आपको कोई भी चीज मॉनिटर करने की जरूरत नहीं है. आगे मैं बताऊंगा कब करना है. और अगर इनमें से किसी का भी रैंडम ब्लड ग्लूकोज है वो 180 से ज्यादा है और अंडरलाइंग आपको लगता है कि न्यू ऑनसेट डायबिटीज है या पुरानी डायबिटीज है, तो उनको, अगर वो कंट्रोल है तो उनको 2 दिन तक ऑब्जर्व करना है. और अगर वो अनकंट्रोल्ड है, लाइक अगर जिनका पोस्ट पेंडियल 200 से ज्यादा है, रैंडम 250 से ज्यादा है, तो इमीडिएटली फार्माकोथेरेपी स्टार्ट करनी है उसको कंट्रोल करने के लिए, जो मैं आगे बताऊंगा कैसे करेंगे. अगर शुरू में उनका हाइपरग्लाइसीमिया नहीं मिलता है और अगर उसका सीवियरिटी ऑफ द डिजीज बढ़ती है, जैसे माइल्ड से मॉडरेट चला गया, मॉडरेट से वेंटिलेटर क्रिटिकल पे सीवियर पे आ गया, या पेशेंट को स्टेरॉइड दे दी गई, तो फिर मॉनिटरिंग चालू करनी है, जिसमें हम फास्टिंग करेंगे बिफोर लंच, बिफोर डिनर एंड आफ्टर डिनर, 2 दिन तक करके देख सकते हैं. एंड अगेन, इफ इट गेट अनकंट्रोल्ड, देन वी हैव टू ट्रीट. पर्टिकुलरली मॉनिटरिंग हमें उन लोगों में करनी है जो कि एट रिस्क ऑफ द डायबिटीज और हाइपरग्लाइसीमिया है, जैसे ओबीस पेशेंट है, मोर देन 50 ईयर है, अंडरलाइंग कार्डियोवास्कुलर डिजीज है, सीकेडी है. दीज ऑल आर द हाई रिस्क इंडिविजुअल, एंड उनकी मॉनिटरिंग हमें एटलीस्ट डेली 1 या 2 बार करनी चाहिए. अब सोचते हैं कि माइल्ड कोविड, जब हमने मॉनिटरिंग कर ली, इस समय माइल्ड कोविड जो भी आता है, और सपोज करो कि वो माइल्ड कोविड है और उसको डायबिटीज है, तो इस समय हमारा आईसीएमआर के गाइडलाइन में कहते हैं कि उनको होम आइसोलेशन करना चाहिए. मैं मेडिसिन के बारे में उनकी ज्यादा डिस्कस नहीं करूंगा, बिकॉज इतने सारे वेपन कोविड के ऊपर ट्राई किए गए हैं. मेरे ख्याल से कोई भी वेपन उस पर काम करने के अभी तक श्योर नहीं है कि कोई वेपन काम करता है या नहीं करता है. So we all are firing in the different direction with the hope that something will hit the COVID. So I will not go into the COVID treatment. अगर माइल्ड कोविड डायबिटीज का है तो वो घर पे अपना कंटिन्यू मेडिसिन लेता रहे, अपनी डाइट कंटिन्यू करे. क्योंकि कोविड एक्यूट वायरल इन्फेक्शन है, तो अवॉइड एक्सरसाइज, घर पे रेस्ट करे, अपनी ब्लड ग्लूकोज फ्रिक्वेंटली मॉनिटर करे. देर हमारे यहाँ हॉस्पिटल में हमने टेलीकम्युनिकेशन कर रखा है, हमने अखबार में और सबको नंबर दे रखे हैं, so they can have the telecommunication with our medicine department or the endocrine department, and we upscale the drug if blood glucose passes 200. This is about the mild. So here I will also tell about the drugs in the oral drugs. So metformin has been associated with a favorable outcome. metformin में ऐसा बताया गया है कि जो लोग metformin लेते हैं उनका कोविड आउटकम इज बेटर, क्योंकि metformin में एंटी इन्फ्लेमेटरी प्रॉपर्टीज होती हैं. और नॉट ओनली दैट, मेटफॉर्मिन होता है वो एस रिसेप्टर को फास्फोराइलेट कर सकता है. सो दिस इनहिबिट द एंट्री ऑफ द कोविड वायरस इनटू द सेल, एंड मेटफॉर्मिन में एंटीऑक्सीडेंट प्रॉपर्टी होती है. बट एक ध्यान रखना है कि ये माइल्ड केसेस के लिए ठीक है, मॉडरेट जो कि ओरली ले सकते हैं तब तक ठीक है. अदरवाइज वी हैव टू स्टॉप इफ देयर इज अ रेस्पिरेटरी डिस्ट्रेस, रीनल इंपेयरमेंट और हार्ट फेलियर. इफ यू लुक एट द अदर ओरल ड्रग्स, दूसरी ड्रग की बात करें, सल्फोनिलूरिया माइल्ड केसेस में कंटिन्यू रख सकते हैं जब तक कि वो नॉर्मल डाइट ले रहा है. अगर उसको डाइट में कमी आती है या भूख में कमी आ जाती है तो फिर बंद कर देना चाहिए, या दोज पेशेंट हु रिक्वायर द आईसीयू एडमिशन, ऐसे में हम सल्फोनिलूरिया बंद कर देंगे. पाइग्लूटाजोन में भी एंटी इंफ्लेमेटरी प्रॉपर्टीज बताई गई है, बट इसके साथ में फ्लूइड रिटेंशन और इडिमा की प्रॉब्लम रहती है, और इनमें से कई पेशेंट ARDS और हार्ट फेलियर में जा सकते हैं। इसलिए हीमोडायनामिक अनस्टेबल पेशेंट्स में हम ट्राइग्लूटाजोन यूज नहीं करेंगे। दूसरी ओरल ड्रग्स के बारे में बात करें तो GLP-1 है, वो ACE2 लेवल को इंक्रीज करते हैं कार्डियक और पल्मोनरी टिश्यूज पे। सो देयर इज ए पॉसिबिलिटी ऑफ द पुअर आउटकम। दैट्स व्हाई we are yet silent on the practical guidelines or significance of the GLP-1 use in the COVID. DPP-4 inhibitor, they may also have the adverse effects, and the clinical trials are going on. So at present, if the mild case is there and patient is taking, we continue, but moderate cases or hospitalized patient, we stop the drug. जहां तक SGLT2 इनहिबिटर का बात है, इसकी भी एक ट्रायल चल रही है डापाग्लोफिजिन के साथ में, उन्होंने इनिशिएट की थी, जिसमें they were looking at the infection, complication, death, बट इस ट्रायल के रिजल्ट नेगेटिव आ गए, तो न पब्लिश हुई, न उन्होंने इसको एनकरेज किया। However, SGLT2 may cause dehydration and euglycemic decay, and that's why it is better to be avoided. अब बात करते हैं मॉडरेट और सीवियर कोविड की। जब भी मॉडरेट और सीवियर कोविड, मुझे बताने की जरूरत नहीं है कि हम मॉडरेट है जब रेस्पिरेटरी रेट more than 24 per minute और SpO2 level more than 94% with respiratory distress अगर होता है तो we call it moderate, and when respiratory rate is more than 30 and saturation is less than 90, we call it severe. And these both the cases we admit and they require the oxygen therapy. So these patients are usually admitted, and as per the ICMR guidelines and Ministry of Health guidelines, we give the steroid to them. I will talk about the steroid little later on. And there we require the frequent blood glucose monitoring. And here we always give the insulin therapy if the blood glucose is more than 200. And let's see what we do. Basically, insulin is a beneficial to all patients in all kind of infection in all situations. And they have the anti-inflammatory property and which may be beneficial. So also it has been seen that those patients who are treated with insulin और जिनको इंसुलिन नहीं मिला है, इंसुलिन वाले पेशेंट का ब्लड ग्लूकोज एट द एडमिशन इज मच मच बेटर देन those who are not getting the insulin therapy. So what if you look at this graph on the left side, A is the patient without diabetes and this is with diabetes, and if you look at the procalcitonin level, go hand in hand with the glucose and insulin therapy was given even in non-diabetic patients up to the 50 units per day, and those who the diabetic, they have given up to the 250 units per day. But if you control the blood glucose level, your procalcitonin level also comes down. That means they are less likely to get the infections. So at present, we are keeping the target between 100 to 180. As I told you, our own data that more than 80, and also Spanish study, more than 180, they had the very, very high mortality, 2.5 times. So we are keeping our target between 100 and 180 milligram per deciliters. This is my old slide, which nursing has seen, and most of you have seen, that I believe in giving the insulin infusion therapy. So in my hospital, all COVID patients, moderate and severe cases, those having the blood glucose more than 200, we are controlling by the insulin infusion. And it is my formula is very, very simple, that blood glucose upon 100 is equal to units per hour. अगर blood glucose कम नहीं हो रही है तो 2 घंटे बाद में आप 0.5 या 0.1 यूनिट उसमें ऐड कर सकते हैं, और अगर ब्लड ग्लूकोज 100 से नीचे जाता है या नहीं जाता है तो उसको हम 0.5 या 1 यूनिट से कम कर सकते हैं. बट कोविड इज इंसुलिन रेजिस्टेंट स्टेट, इन्फ्लेमेटरी स्टेट, द रिक्वायरमेंट इज मच मच हायर. अगर ब्लड ग्लूकोज कभी 100 से कम हो जाता है तो हम आधा घंटे के लिए ब्लड ग्लूकोज बंद कर देते हैं, आधे घंटे बाद में हम ब्लड ग्लूकोज वापस देख लेते हैं, क्योंकि इंसुलिन की हाफ लाइफ 3 to 5 मिनट्स होती है, तो 6 हाफ लाइफ 30 मिनट्स बाद में इंसुलिन अपने ब्लड से इंट्रावास्कुलर कंपार्टमेंट से चला जाता है. तो और जब भी इसका ब्लड ग्लूकोज वापस ऊपर से 100 आता है तो हम वापस इंसुलिन इन्फ्यूजन चालू कर सकते हैं. जैसा कि मैंने शुरू की फर्स्ट स्लाइड में बताया था कि लेस देन 70 is also harmful. So if blood glucose 70 से कम जाता है तो we can give the 50 ml of the 25% glucose, which will raise the blood glucose by around 60. So it will come around 130, 140, which is acceptable. ग्लूकोकोर्टिकोइड जैसा मैं बता रहा था कि ये गाइडलाइंस है, ये सर्वाइविंग सेप्सिस कैंपेन कोविड की फर्स्ट गाइडलाइन है जो कि मार्च में पब्लिश हुई थी. And they also recommended that in case of the moderate to severe or critical COVID-19, we can give the short course of the steroid therapy. And there is high quality evidence that they reduce the mortality. And there is a short course का there is a बिल्कुल कम इफेक्ट होता है, अफोर्डेबल है, वाइडली अवेलेबल है. लेकिन इंडिया में क्या हो रहा है कि जो भी हॉस्पिटल में भर्ती हो रहे हैं उनको तो सब डेक्सामेथासोन और प्रॉपर्ली 5 to 10 डेज मिल रहा है. लेकिन हमारे यहाँ हमने देखा है कि जो पेशेंट माइल्ड और घर पे हैं and those who are treated by the private practitioner outside, I have seen they are admitted with the mucormycosis. They have been given 1 gram methylprednisolone TDS. I have the prescription of 150 milligram methylprednisolone TDS for 7 days. So this kind of the steroid therapy is probably harming and they causing the more onset of the diabetes and hyperglycemia, and both together become the fertile soil for the mucormycosis. At present, we have the till today 133 cases of the mucormycosis which we are treating. So recommendation is using dexamethasone if it is available over the other steroids. Straight away, surviving sepsis guideline, MOSW guidelines, they say that dexamethasone or equivalent doses. So dexamethasone is probably better. 6 milligram IV once a day from 5 to 10 days. People take it as a 10 days. If you read the guideline, they say up to 10 days. So all the moderate cases, when they get admitted, my clear instructions are there that patient is get admitted, you observe for the 48 hours. If patient is showing the improving side, you stop after 5 days. If patient is deteriorating, then you can continue up to the 10 days. But at 10 days, we must stop. So that is what we are doing for the glucocorticoids. And whenever you give the glucocorticoids for the long time, they cause the hyperglycemia, they cause the worsening of the diabetes, avascular necrosis, psychosis is given for the long duration. And they may raise the blood glucose level up to the 80%. And they also exposes to the infections. So steroid will cause the deterioration of the metabolic control definitely. And you have to be watchful. Even if initially patient was mild, well controlled, he goes toward the moderate side, believe me, their blood glucose is going to be uncontrolled and they should be monitored. So one thing is there that there is an old literature is there where prednisolone, if you want to give the prednisolone, then prednisolone duration of hours is 8 hours. It peaks around 3 to 4 hours. So if you giving the prednisolone as a one dose, you can use the NPH because their both profile is same. NPH peaks around 2 to 3 hours, duration is 8 hours. So if you are giving only one dose of the prednisolone, you can use the morning NPH alone. And the adjustment is 0.1 unit per kg for every 10 milligram of the prednisolone, up to the 0.4 unit per kg with maximum of the 24 units. This is for the prednisolone given once a day. But since we are giving the dexamethasone, which is a long acting, so insulin infusion still remain the choice for the controlling the blood glucose. And once after 10 days, when you stop the steroids, it may be that insulin requirement may go down and hence you have to reduce the doses. So to conclude, patients with diabetes are predisposed to COVID-19, they are getting more COVID-19. There is a rapid and severe deterioration of the metabolic control in people with the pre-existing diabetes, and there is a high chance of getting the new diabetes or new onset hyperglycemia. The pure glycemic control at hospital admission and during hospital stay also worsens the outcome in patient with COVID-19, and in people with hyperglycemia, glucose control should be meticulous and any metabolic complications should be treated vigorously by IV insulin. Thank you very much. I have kept it short because nursing told me that I have to keep it around 20 minutes. So yes, I've taken a little more time. So it was a short presentation. So now stop sharing. Yes. So I am.
बहुत बहुत धन्यवाद सर, आपने बहुत ही शार्ट में चीजों को समझा दिया, जिसके लिए ये कहा जा सकता है कि आपका जो समझाना था वो उसी प्रकार था जैसे कि कहा जाता है कि बिहारी के दोहे जो हुआ करते थे कि देखन में छोटे लगे घाव करें गंभीर, तो वो स्थिति थी। बहुत अच्छी तरह से आपने बताया। और अब मैं और डॉक्टर मनोज श्रीवास्तव आपसे कुछ ऐसे प्रश्न पूछेंगे जिनको हम लोगों ने पहले से सोचा था कि ये पूछा जाना है, और इस बीच में जो और प्रश्न आएंगे लोगों को, उनके जवाब भी आप सब देंगे, और हम लोग को अच्छा डिस्कशन का टाइम मिले, इसीलिए हम लोगों ने इसको शार्ट रखा था। तो सर, पहला प्रश्न जो है उसका उत्तर हालांकि आप काफी हद तक दे चुके हैं सर, लेकिन पहला प्रश्न जो आता है सर वो ये आ रहा है कि जो लोगों की तरफ से था कि प्रश्न पूछना है, और ये प्रश्न लोग चाहते थे कि पूछा जाए, इसलिए इस प्रश्न को पूछा जा रहा है। और ये प्रश्न सर है कि क्या हाइपरग्लाइसीमिया अगर किसी को रहती है, डायबिटीज का मरीज है और उसको हाइपरग्लाइसीमिया है, अनकंट्रोल्ड डायबिटीज है, तो ऐसे व्यक्ति को क्या कोविड का इन्फेक्शन होने की संभावना जो कंट्रोल है उसके तुलना में ज्यादा है क्या?
ये तो मैं अपने, जैसे मैंने शुरू में ये बता दिया था कि हमने चाहे स्पेनिश स्टडी देखें, चाहे अमेरिकन स्टडी देखें, चाहे इटली की स्टडी देखें, चाहे हमारी खुद की देखें, उसमें जो डायबिटीज के मरीज है वो अराउंड 70 to 20% है, जबकि हमारी जनरल पॉपुलेशन के अंदर डायबिटीज ओनली 9 to 10% है। दैट मीन्स कि डायबिटीज के मरीज हैं उनको इन्फेक्शन होने के चांसेस डबल रहते हैं, बिकॉज दे हैव द इंक्रीज एज टू एक्सप्रेशन, एंड दैट इज प्रोबेबली रीजन इज गिवन that diabetes patients are more likely, particularly those who are uncontrolled, to get the COVID.
Manoj.
So you had been very, what you call lucid and very comprehensible as far as the talk on COVID was concerned. एक सवाल और हम लोगों के दिमाग में अक्सर आता है, हमारे डायबिटिक पेशेंट्स हैं जो एस्पिरिन ले रहे होते हैं, एंड जैसे कहा जाता है कोएगुलोपैथी एक पार्ट है कोविड डिजीज का खुद, और डायबिटिक्स देमसेल्व्स आर प्रोन टू लॉट ऑफ कोएगुलोपैथीज, तो ये कॉम्बिनेशन में डेफिनेटली कोएगुलेशन डेफिनेटली बढ़ता है। तो क्या ऐसे पेशेंट्स को इकोस्प्रिन के साथ एंटीकोएगुलेंट साथ में शुरू कर देना चाहिए, या उनका इकोस्प्रिन बंद करके एंटीकोएगुलेंट शुरू करना चाहिए, या उनको इकोस्प्रिन पे कंटिन्यू करना चाहिए जब तक कि हमको कोई कोएगुलेशन के एविडेंस ना मिले? ये एक सिचुएशन डायबिटिक एंड कोविड के साथ में सर।
डॉक्टर मनोज, ये हमारे यहाँ तो बहुत इस बात पे झगड़ा होता है एनेस्थेटिस्ट और मुझ में, ठीक है ना। हम दोनों का सबसे बड़ा झगड़ा एंटीकोगुलेशन पर ही है। देखिए, एंटीकोगुलेशन है जब तक पेशेंट को कोविड नहीं हुआ है और चलता फिरता आदमी है, माइल्ड भी है, घर पे चल रहा है, देयर इज नो रिक्वायरमेंट ऑफ एंटीकोगुलेशन। दैट इज द फर्स्ट फुल स्टॉप। दैट माइल्ड केसेस रोमिंग अराउंड, वॉकिंग अराउंड, no requirement of the anticoagulation. Those who are having the moderate or severe, they require anticoagulation definitely, because this is hypercoagulability, and we have seen the cases of the arterial thrombosis, pulmonary embolism, pulmonary thrombosis. We have seen all cases, even the peripheral we have seen. Thing is that in those cases of the moderate, at present recommendation is to give the prophylactic anticoagulation therapy. That is, we give the enoxaparin 0.4 milligram per kg body weight. Those who are having the evidence of any thrombosis, they should be given the therapeutic doses of the anticoagulation. Otherwise, anticoagulation is a double-edged sword. I have seen the patients getting the bleeding and dying because of the thing. So it is a double-edged. That I have seen the 27-year-old patient in the ICU was given the anticoagulation, and he had intracranial bleed and died. So, which patient will bleed, you do not know, and which patient will have the thrombosis, you also don't know. So we have to look at those patients of the higher risk of the bleeding. In them, it is better, just like old age, recent bleeding, or you have the underlying cardiovascular disease, uncontrolled hypertension. In those patients, you have to take a little bit more care. But in diabetic patients, at present, recommendation remains which is the MIHW guidelines or the surviving sepsis guideline, that patients without evidence of the thrombosis, we give the prophylactic anticoagulation in moderate to severe cases, and those evidence of the embolism or thrombosis, we give the therapeutic. At home, at present, I do not recommend any anticoagulation therapy.
So ecosprin का क्या करना है once they are hospitalized?
The ecosprin can continue. Ecosprin, because all the hypercoagulability is because of the coagulation factor. It is not because of the platelet. That's why aspirin can continue.
Higher risk of bleeding तो नहीं हो जाता sir with both continuing with aspirin and
look, we have not seen with aspirin, those who have the double aspirin plus clopidogrel, we have seen the bleeding. But aspirin alone, I have not seen any case. Aspirin plus this, we have seen the hematemesis in the 2 or 3 cases. We stopped and they recovered. And we have done the endoscopy in them, and there was no ulcer, no other cause was there. Simply stopping dual anticoagulation had stopped the bleeding.
डॉक्टर नरसिंह सर।
सर आपने बहुत अच्छी तरह से इस एंटी कोआगुलेशन वाली चीज को समझाया। सर हमारे केजीएमयू में 3 थे हमारे डेंटल के, और मुझसे उम्र में छोटे थे 1-2 साल, हालांकि सीनियर है मेरे। वो उनके साथ यही हुआ, वो डिस्चार्ज होने वाले थे और उनको एंटी कोआगुलेशन थेरेपी दी गई और वो ब्लीड कर गए और उनकी डेथ। तो इस प्रकार के केसेस यहाँ भी रिपोर्टेड केजीएमयू में भी हैं। सर एक सवाल बहुत अच्छा हमारे जो लोग सुन रहे हैं उनकी तरफ से आया है कि इस कोविड ने इंफ्लेमेटरी मार्कर्स को बहुत ज्यादा हाईलाइट कर दिया। लोग सीआरपी करा रहे हैं, IL-6 करा रहे हैं, बहुत सारे करा रहे हैं। तो क्या रूटीन डायबिटीज के प्रैक्टिस में भी इंफ्लेमेटरी मार्कर्स का रोल आने वाला है क्या?
देखो नरसिंह, मैं शुरू से आप लोगों के साथ रहा हूं, एंड आई ट्रीट द पेशेंट, आई डोंट ट्रीट द रिपोर्ट्स।
बहुत अच्छा, यही सुनना चाह रहा था सर।
तो मेरे यहाँ हमारी स्टडी जो हमने की है, मैंने कोविड के अंदर वी हैव अराउंड नाउ 27 पब्लिकेशंस। सो पहली चीज तो ये कि IL-6 हैव द नो क्लियर कट डिमार्केशन बिटवीन माइल्ड, मॉडरेट एंड सीवियर। CRP हैव, so higher the CRP, more severe is the disease, there is no doubt about it. But look at the CRP and you start treatment, patient is absolutely normal? No. I have seen the patient with the IL-6 of 6,000. My own consultant, mild cases, I have not given a single drug to him. People were after him to get admitted. Nothing. Severity is decided by the respiration and SpO2, not by the IL-6.
Good, sir. Good.
And we have not a single patient we have treated on the basis of either CRP or IL-6, and even the D-dimer. Though recommendation is there that D-dimer is more than 5 times, you start on the anticoagulation, blah, blah. I usually say these all are reflection of the underlying inflammation and they do not reflect the severity of the disease.
सर हमारे साथ एक बहुत अच्छे हमारे सीनियर डॉक्टर जुड़े हुए हैं, डॉक्टर विजय पाटनी कलकत्ता से हैं। तो इनका एक प्रश्न है कि जो निमोनिया है, ये निमोनिया है या इम्यूनोवैस्कुलोपैथी है? सिविरिटी का कारण क्या है इन पेशेंट्स?
लुक, सिविरिटी का कारण जो हम लोगों ने MBBS में 30 साल पहले पढ़ा था वही है कि जब भी कोई निमोनिया होता है तो देयर इज अ स्टेज ऑफ इन्फिल्ट्रेशन, रेड हेपेटाइजेशन, ग्रे हेपेटाइजेशन एंड रिजोल्यूशन. And along with every inflammation, there has been microangiopathy or microthrombotic episodes are there. If you remember, recollect, we have tried the APC, that is protein C. APC is about 20 years back. We have given in case of the septicemia, which later on got, because was a thrombosis were occurring. Activated protein C complex we have given around 20 years back, and it is gone. So for every inflammation, the coagulation factors are also affected. So basically, it is a pneumonia. Along with there is a vasculopathy is there, no doubt about it. And hence, people talk about the CT severity index. So they don't realize that when patient is having the infiltration, CT index will be low, patient may have the more symptoms. When they have the red or gray hepatization, it is a solid structure, your CT score will go high, but patient will be on the recovering stage. So that's why we never get the CT done in each and every patient. And we don't give any damn to the CT score in IMS Jodhpur. We only go by the respiratory rate and SpO2. We don't treat the CT. We treat the patient functional status.
डॉक्टर गर्ग, एक सवाल हमारी तरफ से और था कि आपने न्यू ऑनसेट डायबिटीज की बात करी है इन कोविड पेशेंट्स, तो ये क्या जो हॉस्पिटलाइज पेशेंट्स है उनमें ही देखा जाता है या जो होम आइसोलेशन वाले हैं माइल्ड टाइप के उनमें भी हो जाता है? उसका सेकंड पार्ट सर एक और था सर कि ये जो डायबिटीज आती है न्यू ऑनसेट डायबिटीज, इट इज अ वेरी सिवियर फॉर्म ऑफ डायबिटीज और इट्स अ माइल्ड डायबिटीज?
No, it's mild also. We have seen at home isolation also, because home isolation patient we give the this state government give their kit, blah blah blah. So very less patients are under our follow, because whenever they come to the flu screening desk and they fit in the mild category, we send them home and inform the state authorities. So the CMNHO have the contact with them. We normally do not have the contact with them. Only the diabetic patients who are in the mild category, we tell them that if you require, you can have the telecommunication. But when you are telling this, we realize that when patients come in the moderate stage and suddenly we find the blood glucose is higher, that means it has happened in the mild stage. Somewhere it has started. So when mild cases also may get the new onset diabetes, because this is virus have the cytopathic effect on the pancreatic beta cell. Plus you have the inflammatory marker which is causing insulin resistance. So there are the two things, insulin deficiency and insulin resistance. Both are occurring simultaneously in the given patients. And that's why they are more likely to get the diabetes. And we are getting the patients post-COVID. COVID ho gaya, now we are running the post-COVID clinic. Every Saturday we run the post-COVID clinic, and in them we are finding more new onset diabetes. Pehle diabetes nahi thi, but now they are presenting with the diabetes. So you are right that new onset diabetes can occur post-COVID also. It is not only when the patient is presenting. Post-COVID we are seeing the new onset diabetes.
सर कुछ की रिवर्सिबिलिटी भी देखिए सर, कोविड ठीक हो गया, चली गई हो डायबिटीज?
Look, that we are following it up. I don't have the data at present, right? But we are following and we are trying to see whether we have seen the adrenal insufficiency, we have seen the low T3, low T4 syndrome, we have seen the hyperprolactinemia, we have seen the new onset diabetes. This all endocrine already it is accepted. It's going to be published. So we are following it up whether they recover and what happened to them. So this we are still under the evaluation.
थैंक यू
डॉक्टर
सर।
वर्मा,
सर एक बहुत अच्छा प्रश्न पूछा है हमारे यहाँ डॉक्टर सचिन द्विवेदी ने। ये जानना चाहते हैं हाउ टू आइडेंटिफाई स्टेरॉइड इंड्यूस्ड हाइपरग्लाइसीमिया, whether any warning sign to detect or just we keep on monitoring for blood sugar?
Look, so simple. If it is steroid-induced hyperglycemia, you do the A1C, it will be normal, because A1C will rise after 3 months. So steroid-induced hyperglycemia, it will occur immediately, and only way to see is that you have to do the capillary blood glucose or the plasma blood glucose. That is the only way to detect. Those patients who are having the infections, they are obese, they have family history, they are more likely to have the precipitate. They may be pre-diabetic, and by given this all the scenario, by the insulin resistance, insulin deficiency, inflammatory marker steroid, they will precipitate the diabetes in them. And then Dr. Manoj was telling, they may recover, but later on they will again become diabetic. So this may be the sequence. So you have to be vigilant on them. There is, you can say, risk if you look at the family history, if it is obese, hypertension, underlying heart disease, plus you are giving a steroid, they are more likely to have the diabetes.
सर एंटीकोagulation पर बहुत से प्रश्न आ रहे हैं। एक प्रश्न है डॉक्टर विश्वास का कि एंटीकोagulation in pre-existing diabetes with pregnancy in first trimester.
Look, anticoagulation in the first trimester, I will not, only low molecular weight heparin can be given. And this, we have the lot of pregnancy with the COVID, and they have delivered, but all the cases were mild. Touch wood, only we have lost only one case of the pregnancy, which was severe COVID. The child survived, the mother died. We have given the low molecular weight heparin, and that is very well given in the pregnancy. There is no problem.
एक और रिवोरोक्साबैन पे एक सवाल है डॉक्टर इस्मत रेहाना का, but this is for a non-diabetic patient. Whether we should be taking it in this forum or not, it's a non-diabetic, and she had been put on rivaroxaban for 10 milligrams for past 10 days. How long should we continue with this?
Look, we are using, because there is a literature of the COVID on the apexaban. Rivaroxaban, there is a less literature. Apexaban literature is there. Those patients who are, you cannot give the low molecular weight heparin, or those who refuse, you can use the apexaban instead of this heparin. We have experience of very few patients on the apexaban. Rivaroxaban we are not using. We are only apexaban, and we are using the 5 milligram BD tablets. And we have the recently Bapuji Asaramji who refused low molecular weight heparin, so we had to give, but he developed the hematemesis and we had to stop it. So I told you, I'm very, very cautious about giving any anticoagulation, excessive anticoagulation, because primum non nocere, my drug should not harm the patient.
How
That is
long would
my
you like to give that, sir? How long?
duration is same. Duration is same, that during the time of this ICU admission, you continue to give, and when patient become ambulate and patient is about to discharge, so your all the parameters are normal, your respiratory is normal, you are without oxygen, you are not on the drugs, you are on normal diet, and you are going home and you can walk around. Once patient is ambulant, you can definitely stop it. Though some literature is coming in that you must continue for 2 to 3 months, but they are not randomized trial and they are all opinions. So that's why at present they remain at the opinion state. Just like I told you initially that we and anesthetists have the long fight. I want, don't give, they say give, right? Because they treat the lying patients and we treat the ambulant patient.
Dr. Verma, please. You are muted, sir.
सर एक सवाल बहुत अच्छा आया है कि कोविड पेशेंट्स डायबिटीज होती है तो अपॉर्चुनिस्टिक इन्फेक्शन बढ़ जाते हैं। ऐसी कंडीशन में उनका सवाल है कि कुछ पेशेंट में उन्होंने पाया है कि अगर निमोनिया परसिस्ट कर रहा है तो उसमें एएफबी पॉजिटिव भी पाया गया, तो क्या ऐसे जो जिनमें निमोनिया लंबे समय तक रहे वहां हम ट्यूबरकुलोसिस को सस्पेक्ट करें?
Look here, you have to remember that outside all the patients of the COVID pneumonia, moderate to severe, though we are not using tocilizumab much, we are giving very, very sparsely. Outside, people have been given plasma therapy, tocilizumab, remdesivir, steroid, oxygen, whatnot. You have to look at the tocilizumab is an anti-IL-6, and half-life of tocilizumab is 13 days. So they will remain in the body for 65 days, 2 months. It will depress your immunity or fight against the infection. And that's why one of the criteria for the tocilizumab is you should not have the underlying bacterial or fungal infections. So when we get the Procal, we get the galactomannan done to see that they should not have the underlying bacterial or fungal infections. So now I'm coming to nursing's questions, that if these patients are given all the drugs, they will have the prolonged pneumonia, then first suspicion should be fungal rather than tuberculosis. And we have found many cases of the fungal pneumonia, in this case, particularly aspergillosis and candida. And then AFB may be found, right? Any patient can have the decreased immunity, any bacteria can flourish. So if they are not recovering long time, we first think of the bacterial as well as the fungal pneumonia rather than tuberculosis. That is our approach, and we have treated many patients with the higher antibiotics as well as the antifungal drugs, and we could pull them out.
So chat box में एक और सवाल है आपके लिए, again with anticoagulation. How much importance do you give to D-dimer in starting your anticoagulation and stopping the anticoagulation or titrating your dose further? D-dimer का क्या role है सर? कितना importance देते हैं आप उसको सर?
Look, as a clinician, I'm telling you that I don't believe in the reports, I believe in the patients. I've seen the patients in my moderate category, D-dimer is going to 5 to 10 times, but they are ambulant, they are going to the bathroom, they are well, there is no other feature is there. I say, okay, prophylactic dose is good enough. And as soon as they are shifted to the intensive care unit, and you find that D-dimer more than 5 times, guidelines are there, give them therapeutic dose. So it's all, as a clinician, you have to take a call. Which one do you want to use? If you want to go according to guidelines, they say that in the moderate category, you give the prophylactic dose. If evidence of the severe or the embolism, this thrombosis, you give the therapeutic dose. This is the guidelines. Rest is your physician, and you are the best to judge the patient.
No mention of D-dimer in the guidelines.
No mention of the D-dimer in the guidelines.
Dr. Verma, please.
Yeah, sir. Role of anti-fibrotic agents post-COVID?
At present, we are not giving it, firstly, right? Though outside everybody is prescribing them, we are not giving it. We are running a post-COVID clinic. There are the many patients who have developed the fibrosis. We are seeing that patient. But if you look at, we have treated 6,000 patients, and hardly we have seen the around 8 to 10 patients who have we are not able to wean off the oxygen. And if you do the repeat CT, there is evidence of the fibrosis. So at present, there is no guideline that we must give the fibrotic agent firstly, because there is a long time effect. Study will be coming out in the future, but as of today, we are not giving it.
सर कुछ लोगों का ये सवाल है सर कि जो पेशेंट अक्सर पेशेंट कहता है कि साहब आपने स्टेरॉइड दिया और हमें इंसुलिन दे दी, इंसुलिन से कवर कर दिया है, क्या हमारी ये इंसुलिन बाद में फिर से OHA में कन्वर्ट हम हो जाएंगे या इंसुलिन हमें अब हमेशा लेनी पड़ेगी?
Only this thing only can be told by the monitoring and future things, because when infection goes, your insulin stress will come down, your daily activity will start, and how your blood glucose behave, you tell the patient that depends on blood glucose. You cannot predict. हो सकता है वो बिल्कुल इंसुलिन से भी चले जाए, OHA से भी चले जाए, हो सकता है OHA से कंट्रोल हो सकता है. It depends on the blood glucose values. But suppose he's coming with the A1C of the 10 or 11, then you have to tell them that, look, your blood glucose is not controlled. You will require the insulin therapy. So this what we are doing last 30 years, that you look at the patients and the A1C is more than 10. I don't think that any oral drugs can bring it down to 7.5 or 7. Ultimately, you have to go on the injectable therapy or insulin therapy to bring it down. So that is the best time to convince the patient that yes, you require the insulin therapy.
So another issue, please.
Dr. Navida Nishat wanted to know one thing, that most of the patients of the COVID, they develop low-grade fever even after COVID. So
very good questions. I have around, you may say, hundreds of the patients. They have complained that they have the 99 to 100 in Jodhpur, all over the India. Whatever my well-wishers are there, they ring me up, and they are getting 99 to 100 fever up to the 21 days I've seen. I don't give anything.
you wanted to know whether it is related to diabetes?
No, non-diabetic also. I have seen the young patients also. I have seen the VVIV patients. Right, they go outside and they have been given all the Enteric and this and cefotaxime, and they report to AIMS. They come to me. I say stop everything. One VIP, I have to tell that please you break this your thermometer. You will not take the temperature because it's become they become so strict. Every hour they take the temperature and message me, Doctor Sahab, ye temperature. Now VVIP patient, you cannot ignore them also. And then I had to really tell them that please break your thermometer. You will not put that in your mouth. And really, after 3, 4, 5, 6 days, I see the train is same, 99 to 100, maybe 100.1 sometime. This low-grade temperature I am seeing in many patients, which last up to the 21 days. And they all become all right, they disappear. Because apprehension is much, much more. कि साहब बुखार नहीं जा रहा है, साहब हमें कुछ हो तो नहीं जाएगा. That apprehension, I always say that one of the lady, VIP wife's lady, she was virtually sitting with the thing, सब ये 92 हो गया, 93 हो गया. मैंने कहा मैडम इसको उतार के फेंक दीजिए. आप चल सकती हैं, आपको सांस नहीं फूल रहा है, आप घर का काम कर रही हैं, forget. Don't look at that SpO2 probe. It's very difficult to convince the patient because the fear psychosis is such a high in this disease that everybody thinks कि ये उतारा नहीं और मैं मरी नहीं. डॉक्टर साहब उतार दूंगी और ये कम हो जाएगा तो मेरा क्या होगा? मैंने कहा आप उतार देंगे तो बहुत अच्छे हो जाएंगे. So that kind of the fear psychosis you have to deal with the patients.
Especially sir, with low grade fever and those markers high, this combination, this is really a headache to all physicians, I suppose.
Look, I told you first sentence, I treat the patient, not the investigations. And I'm telling you markers, I've told you my consultant examination. I don't look at the markers. I look at the patient. Patient is absolutely normal. He's walking around. His diet is normal. His respiration is normal. His SpO2 is normal. What for you are treating? So you are not treating, and fear is again कि मुझे thrombosis तो नहीं हो जाएगा, कल मैं मर तो नहीं जाऊंगा. Nobody knows. So basically, I treat the patient condition. You look at the patients and then you treat. And at present, I'm very sorry to say that all the outside colleagues, they all are treating reports. And when they come to me, I stop everything and they become all right. My own colleagues, doctor colleagues, they are taking self-medication of the steroid in a mild stage. And it's very, very sorry affair that this kind of the things where the first week steroids are contraindicated, clear cut. Okay, the COVID steroid are to be given only in the second week, not in the first week. First week mein viral replication is going on and it will adversely affect the viral replication. So one has to understand this, all the things, but it happens. Hello, Narsingh, it was a wonderful to being with you all, and keep it going. यूपी के पाठशाला के विद्यार्थी सब हैं, ये विद्यार्थी हम सब इससे ज्ञान प्राप्त करते रहेंगे और इसमें फिर मिलते रहेंगे।
सर, अपने करीब 65 लोगों ने आज ज्वाइन किया और प्रश्न पूछे हैं, और प्रश्न तो अभी आते जा रहे हैं परंतु समय सीमा है। एक प्रश्न और सर चलते चलते है कि पेंटॉक्सीफाइलिन के बारे में पूछ रहे हैं डॉक्टर साहब कि क्या पेंटॉक्सीफाइलिन का कोई रोल है?
No experience, no role as far as me is concerned.
Thank you, sir.
So one more last question, sir. Post-COVID tachycardia.
Yeah.
How do we go about it, sir?
Look, at present we are doing I told you the post-COVID clinic is going on around now 6 months. Around 10% of the patients we are finding they raised pro-BNP, systolic dysfunction, not right ventricular dysfunction, left ventricular systolic dysfunction. Because suppose if we thought that it is a lung disease, so basically the right ventricle should have been affected. But here we are finding the left ventricular dysfunctions, and 10% of the patients we think it is a myocarditis. Now, whether it is a directly COVID related, COVID antibody related, it is a vaccine related, whether it's a drug related, all speculations. But we are finding cases of the sixth sinus syndrome, we are finding bradycardia, we are finding tachycardia, this kind of the things we are finding. And at present, we think there is a mild variety of myocarditis which may last for some time, or what will happen to them, we are following on. But definitely, in the post-COVID clinic, around 10% of the cases we are finding those who have the mild to severe disease, moderate to severe disease, they have some kind of the myocardial dysfunction.
Including hypertension also, blood pressure going up, sir?
No, hypertension we are not finding.
People did not had hypertension previously, and during this period, the blood pressure goes up.
No.
Could be because of underlying anxiety, probably.
Maybe underlying anxiety may be the reason. But definitely myocardial dysfunction we are finding, and we are following them up. Let's hope they all recover.
तो सर बहुत ही अच्छा आपके साथ डिस्कशन रहा, और जब आप साथ होते हैं तो समय पता नहीं लगता, लगता है कि बात करते ही चले जाएं। तो सर अगला अपना एडिशन 21 को है, और मैडम सरिता बजाज इस समय न्यू जर्सी में है, वो वहीं से ज्वाइन करेंगी, और वो वुमेन एंड डायबिटीज अपना अगला टॉपिक उन्होंने रखा है। तो मैं सभी अटेंडीज से कहूंगा कि एक बार फिर से अपना आशीर्वाद दें, और जैसे जैसे प्रोग्राम और आगे बढ़ेगा, हम अपने सारे जितने हमारे पूर्व अध्यक्ष रहे हैं यूपीडीए के, वो सभी बारी बारी करके आएंगे, और उसके उपरांत हमारे जो चुने गए अभी हमारे प्रेसिडेंट इलेक्ट हैं आलोक गुप्ता साहब, और उसके बाद हमारे दोनों वाइस प्रेसिडेंट डॉक्टर मनोज श्रीवास्तव और डॉक्टर पंकज अग्रवाल। तो ये क्रम इसी प्रकार आगे चलेगा पाठशाला का, तो सभी लोग आनंद लें। और सर आपका दिन बहुत बहुत शुभ हो सर, और आपने अपने व्यस्त समय से समय निकाला, इसके लिए बहुत बहुत धन्यवाद। डॉक्टर संजय अरोड़ा सेक्रेटरी पूरे टाइम रुके, मनोज श्रीवास्तव साहब तो उन्होंने इतने अच्छे प्रश्न पूछे हैं कि पाठशाला जीवंत हो उठी। तो बहुत बहुत धन्यवाद आप सभी को।
हेलो, थैंक यू वेरी मच नरसिंह, थैंक यू मनोज, थैंक यू संजय, थैंक यू वेरी मच, बाय
बाय बाय सर।